Good morning. We're going to continue with our next panel, which is on population health management, a health system perspective. And certainly no discussion of the electronic health record would be complete without addressing the opportunities associated with population health management. Now, by population health management, we mean bringing together the information about the care delivered to large groups of patients in order to better understand how to improve the value of the care delivered to individual patients. So it's about gleaning knowledge and understanding about care in a broad perspective over a large group of people in ways that can drive data-driven care delivery pathways that improve the care for individual patients. And we have a panel of outstanding health system leaders here today on this panel. And I'd like to introduce each of them. I'm going to sort of step back so that they'll have room to step forward and come in here. But first, and this is just in terms of the order of the people seated on the stage here today, Kevin Ban is the Chief Medical Officer at Athena Health. As a practicing physician, he brings more than 20 years of clinical experience, innovative medical system development, along with healthcare practice and performance improvement to Athena Health. And Mark Harrison is the president, and you can go ahead and come up, Kevin. Thank you. Thank you. Mark Harrison is the president and CEO of Intermountain Healthcare, a position he's held since October of 2016. Previously, he held leadership positions at the Cleveland Clinic as the Chief of International Business Development for Cleveland Clinic and as the CEO of Cleveland Clinic Abu Dhabi. Brian Hoberman is the leader of Health Connect, which is Kaiser Permanente's electronic medical record system. He's the leader of Health Connect for the Northern California region of KP, but also for the 8 Permanente medical groups. He's a practicing hospitalist physician whose role with Kaiser Permanente Health Connect began in 2002. Natalie Pagler is the Chief Medical Information Officer for Stanford Children's Health and Clinical Associate Professor of Pediatric Critical Care Medicine at Stanford. She recently helped lead Stanford Children's Health through a transition of its comprehensive electronic health record to Epic. She also serves as Associate Program Director of the Clinical Informatics Fellowship Program at Stanford. And Rishi Sika is the President of System Enterprises for Sutter Health. He joined Sutter in February of 2017 and has executive oversight of the system-wide services, including pharmacy, service centers, home care, laboratories, care coordination, and physician services. So I thought I'd begin with a question for each of the panelists, and maybe, Rishi, we could start with you and then work our way down the row of panelists here. And that is really sort of a broad question, but each of you can choose to focus on the specific aspects that are most meaningful in your environment and in the system you're involved in leading. But that is, how can EHRs be used by health systems to improve value in healthcare, and that is to achieve better outcomes at lower cost? And maybe if you could start by, Rishi, if you could start by describing the landscape today, but also what you see moving forward, and if each of you could be thinking of that as we move to other panelists.
Yeah.
Rishi?
Thank you, Lloyd. And in terms of sort of describing my perspective, I think it's informed both by my current experience and my experience at Advocate Healthcare, which is fairly steeped for probably almost a decade with respect to population health and risk-based design, and Sutter Health, which is increasingly moving in that direction. And when I look at that landscape in terms of what the current state is, a framework that I like to use to think about this intersection of population health and EMRs is a 3-part framework around measurement, resource allocation, and managing the risk. And the issue around measurement is you fundamentally need to be able to know your performance. You need to know how you're performing with respect to quality, with respect to utilization and cost at the individual level, at the practice level, by physician, and in a variety of ways. Measurement is the foundation. The next part, I think, is around resource allocation. You need to understand what are the risk factors in the population that would merit being able to provide certain resources, programs, and interventions. Who would benefit from what? And once you have that piece of resource allocation, then you need to be able to manage the risk. That is, you need to take that measurement, you need to take the resource allocation and the models that drive that, and then be able to integrate that at the point of care so that you know when a trigger occurs, then you can actively intervene on a patient, and being able to do that really within the workflow and in the care cycle itself. Now, I think that's sort of the operating framework about how to understand the current landscape, and that's actually really, I think, what's going to drive forward as well in the future.
Great, thank you. Natalie?
Yeah, thanks. So I definitely have been very pediatric focused, and so I'll take the question from a pediatric perspective. And I think that population health and pediatrics is really kind of an untamed frontier for a couple of reasons. One, because of the relatively lower amount of healthcare dollars that go to pediatrics, and two, because of the relatively small populations of children with disease that we thankfully deal with. And so I think despite those, or partially because of those, there's also a tremendous amount of potential for pediatric population health truly improving the way that we deliver healthcare to children. Because we have much smaller numbers of children with much smaller number of patients with any one particular disease, it's incredibly important that we're able to look at populations beyond our own healthcare systems, congregate data from across the nation, across the world, and really truly define the best practices for children, because in many cases we just haven't done that. So for example, in the treatment of bilirubin, hyperbilirubinemia, jaundice in infants, we have fairly good standards for how to treat your average full-term child, but when you look at the population of premature infants, a very small population, trying to define what the best practice there is challenging. And so the way that population health has the potential to really impact this is by thoughtfully designing our systems to both gather the data that we need, to analyze that data, and then to provide that information to help standardize those practices. So for example, John Palma, who is one of our medical directors of clinical informatics in the NICU here, has created a tool that both standardizes best practice by providing expert-based consensus, but then collects information for each and every case of premature jaundice and stores that, and then they analyze that and use that data to feed back into the clinical decision support tool. So you're really truly creating a learning health system. And like I said, in pediatrics, this is absolutely essential because we haven't defined best practice in many areas.
Okay, thank you. Brian?
Thank you. Population health is just essential to the way that Kaiser Permanente looks at care. We've been value-based care before it was called that. And it was all about prevention and health maintenance. And in this world that we're in now, where we have comprehensive EMR that's used in almost every setting of care, we have a wealth of data that allows us to, as one of my colleagues once put it, see through walls. And in doing that, we were able to recognize care gaps or care opportunities. And then the challenge becomes figuring out which ones of these, because there's so many, rise to the top in terms of priority. And then doing all the thinking and planning work that it takes to figure out how to exploit the opportunity and deliver the real value to the patient. Because it's one thing to be able to compute something, it's another thing altogether to be able to actually execute on it. And it's the execution that we put our main focus on. In fact, about 3/4 of the work that we do on any given technology project, including the population ones, is devoted towards the planning, which mostly includes workflow planning, and only about 1/4 of it goes towards the technology piece of it. But because there's so many opportunities, and because the spectrum of care is so broad, from the littlest and newest patients actually to the pregnancies that lead to them, and then all the way through all aspects of life itself. And because the company is so rich with experts in these areas, we're constantly thinking through where can we find the biggest opportunity that will deliver the most value. And that question is then combined with is there alignment operationally to be able to execute once we figured that out? And that alignment turns out to be challenging because of the scale of the organization. And so an incidental benefit of these kinds of conversations is that we bring people together to discuss these things. And as all of you know who've implemented these sorts of systems, that leads to kind of looking under rocks and all kinds of very useful things happen. And so just the mere task of shining light on something tends to reveal opportunities that are not only related to the population itself, but also to overall care delivery.
Mark?
Thanks. So my gut told me to go with the usual stuff and tell you how we use our EHR to standardize care through care process models and create high reliability care. And that's all true. But this is about population health, and population health is really about keeping people well, is the way I think about it. And I'm kind of obsessed these days with this idea of the 50-40-10 model, where half of your health is your genetics and 40% is your behavior and 10% is what we do in the clinics and hospitals. And recently we've used our EHR to understand the 100,000 full risk Medicaid patients that we take care of, and to analyze what we call ambulatory sensitive conditions. So things that should have been cared for in an outpatient setting that are getting done in the emergency department. And then we went back, and after we identified that, we tried to figure out why people were coming to the ED. And it really turns out that transportation was a huge problem for them. And we've instituted an Uber program for these folks and are seeing enormous changes in utilization of the emergency department. So I guess what my message is to you is that I think the EHR becomes a convener for really interesting ideas that are above and beyond the usual stuff that lots of us have done for a long time. And I'm an ICU doc, a pediatric ICU doc also. And it is weird to be an ICU physician who now all I think about is public health. Right. Yeah.
Great, thank you.
Yeah, they really go from one extreme to the other.
Absolutely.
But I'm going to pick up on your thread, Mark, and say that when I think about successful population health management, and my first experience with that was at Beth Israel Deaconess Medical Center, where we had gotten involved in the Blue Cross Blue Shield AQC contracts, the alternative quality contracts. And so we had risk pushed down onto us. And so what I'll tell you about that experience, and I'll talk more about it, is that this is not really about the electronic health record. That can be a potentiator. What that first experience with risk did was it made us think about how we were delivering care. And we started to go through the practice of practice redesign, transformative care, however you want to refer to it, where all of a sudden it wasn't just about episodic churning and burning of patients, but it was trying to, number one, understand our population, which, by the way, we had no understanding of our population. So we needed technology to aggregate the data and normalize it. Next, it was to really understand, and people have touched on this, who were the folks that we needed to be touching that we weren't, and then how were we going to design care such that we could in a scalable way. So that meant using care managers and nurse practitioners and health coaches and pharmacists, and it became the practice redesign that really drove our outcomes. As we did that, we realized we need more technology to do this. And we need technology not only in the hands of the providers and the care team side, but we need to push that towards the patients. And these are all themes that we're talking about today. So when I think about population health management, and I heard Roy from Humana say in the last panel that we're moving quickly to risk, we're not moving quickly enough to risk. I would guess that 10% of our population is in a risk contract. And as you've all heard before, the concept of interoperability is not a technical problem. It is a political problem. And the moment we incent people to do the right thing is the moment we're going to see them collaborating. We see that in Boston between Beth Israel Deaconess Medical Center and partners. Previously, we never collaborated, not because there were nefarious reasons, but now that there's incentive to take care of populations that run between the two organizations, we figure out interoperability. So for me, we're not getting there fast enough with the thing that we really need, which is incent people to do the right thing, and then they will.
Great. So maybe continuing on that theme, and delving a bit into the policy front, which we haven't talked about a great deal today, but could you, and maybe, Kevin, if you continued on the theme of, it's not the technology that's limiting the interoperability, I mean, by and large. I mean, there haven't been the incentives in place to achieve the interoperability. And you said, I think quite appropriately, that we're moving towards risk assumption on the part of providers and delivery systems, but the pace at which we're making that move is somewhat uncertain, particularly now. So what would be helpful in the policy dialogue, and maybe we can come back this way with that question, starting with you, Kevin. What would be helpful at furthering it? You mentioned, for example, in Boston, that the fact that there is more moving into a risk-assuming environment, and that therefore it became in the interest of both the BI Deaconess and the partner system to be able to freely exchange information, because each was going to lose if they weren't able to. But how does that generalize then to other environments? And by the way, how do you take it out of Boston into other markets?
So I joined Athenahealth 2.5 years ago, and I'm really glad that I did that, because I trained at BIDMC. I was an academic doctor at BIDMC, and I had not seen the world. I can tell you that things that we would frequently discuss in conference rooms are being done in Western North Carolina by Mission Health Partners. They have recognized that this is not about diagnosis and treatment, the thing that I thought it might be about when I first got into pop health, but it's about understanding patients who suffer with behavioral health and who have major social determinants of health. Mark, you mentioned one of the big ones, which is transportation. So I think what we need to do is, I guess I'm not hopeful that we're going to see a lot of legislation that's going to push us closer to risk. But what is interesting and that's happening, commercial payers are getting there at different rates, but it's self-insured employers, really, who are on the hook and who are beginning to push risk onto their employees through high deductible insurance. So I think we're going there slowly in a very unorganized fashion. I think we earlier heard about consumerism. I think more and more as risk gets pushed onto providers, health systems, and onto people, you're going to see a need for the enlightened, consumer-driven patient, and they're going to need to have the solutions, technology solutions, that are technology-enabled services, really, that are going to get them there. So not a really clean answer. I guess I'd like to say, well, I'd love to see our government push us towards that and the commercial payers to follow. I'm not sure that's going to happen. I think it's more likely to be self-insured employers and their employees who are on the hook.
Great. Mark, what are your thoughts?
Great. Well, I'll take a little bit of the same tack. Anish, are you out there? So are you going to talk about the VA pledge during your session? So actually, I'll leave it at that, because I think that's actually a really nice sort of policy kind of piece. I'm actually of the same mind you are, Kevin, that I think this is sort of like solar power, and that economics are going to drive solar power, legislation is not going to drive solar power. I think there's an inexorable move towards value, and I do think that consumerism is going to spin that wheel. Actually, to that end, we brought a chief consumer officer on at Intermountain who actually he was the global head of consumer insights for Disney before he joined us. And he's actually helping us digitalize the system, and we've brought the consumer's voice to the table in every conversation. And I think that's going to be what really drives things.
Great, thank you. Yes.
So I'm in such a different world, right, from this world.
You're in a good world.
Yeah.
Right.
So I guess let me talk about the perspective of the good world.
Yeah.
It's still healthcare. Patients are still patients. And we need to execute to be able to meet their needs. And executing means providing them with lots of different kinds of services, some of which we don't yet understand. But when all barriers are gone, there's still going to be some folks who have their own barriers that prevent them from coming in. We have incredible outreach. We were able to find folks who need to come in to manage their diabetes or their hypertension or whatever, and we're able to actually pick them up. We're able to, find them and all that. And that doesn't necessarily mean that they're going to choose to come in for whatever reason. So the consumerism mindset means kind of meet people where they live, and then it sort of gets beyond the scope of the EMR and potentially even beyond the scope of the health system to say, and then what, right? Because if they're not willing to accept the help that in many cases is free, then we've done everything we can to reach them. But in a world in which the barriers to reaching them are not as severe as they are in the kinds of challenges that other organizations have, what I can say is that the vast majority of our patients are open to that, and they love the easy availability of the services, and we love being able to provide them with the services. So the next step for us, and the thing that we focus a lot on, because the basic population health things we were good at even before we had EMRs, because we had digitized data long before we had EMRs. Now it's about finding the niche populations and understanding where there are care gaps in those niche populations that would meaningfully improve the quality of somebody's life, or other things that are just terribly important to the patients, and not to mention increase the joy in meeting in medicine. Because we as a health system, we don't like to ever have the sense that a mistake occurred because we didn't follow up on something that we should have followed up on. And so we address a lot of our energy towards identifying where those gaps are and using the technology that we have along with the way we organize the organization to be able to close those gaps.
Great. Natalie?
Yeah, I think these contrasts are incredibly important to look at. I think the contrast that Kaiser provides, I just spent the weekend in Toronto at Sick Kids Hospital supporting their EHR Go Live. I've helped with Melbourne Children's Hospital Go Live. And I think some of the issues that Lance Downing and Chris Longhurst highlighted in their paper, the regulatory context that we're in really does significantly affect how we're utilizing these tools, how we're providing healthcare. And I think, as Kaiser has shown, you can operate under a lot different context with the right structure for, or the right you can focus on the right things if you're working in the right context. And so, and again, we were kind of highlighting this in the last panel about how challenging it is, both from the provider perspective and from the patient and family perspective, when you're living in a world of mixed risk models versus value models. You're constantly spending energy trying to figure out what are my options for this patient, or as a patient, how do I figure out what this is going to cost me, or what I can do, what I can't do, and that's wasted energy. So. I don't, living in this country, I don't know quite what the right answer is, but I think it's important that we continue to study these contrasting models and understand how many fewer barriers there are so that we can really start advocating for overcoming some of those.
Thank you. I agree with much of what has been said. I think that the economics will probably fundamentally drive interoperability, but I'm not sure it's going to be sufficient. And let me give an example to illustrate both of those aspects. Now, in my previous organization at Advocate, when we entered into our first commercial ACO contract about 10 years ago, that really drove the need to solve our internal interoperability problem. And we decided to partner with Cerner in a strategic partnership around population health, created a platform that integrated 43 different sources of both clinical EMR data from many non-Cerner EMRs, and then claims data, and then integrating that into workflow. So we had to solve the problem because now we owned and managed the risk. So I think that's an argument that the economics do drive it. But I'm not sure it's going to be sufficient, and that is, I think, because unfortunately, in spite of the fact that we are having this conversation about population health, I do think that there is a prospect over the next decade of seeing an increasing fragmentation of care in our delivery system. And this is a pretty profound macro trend that I think we're starting to see play itself out. So if you go back to the passage of the Affordable Care Act, there was a lot of conversation at that time that we were going to see this great convergence. That is that plans were going to become more delivery system-like, and delivery systems were going to become more plan-like. Well, guess what? It's happening right now. And if I could take the opposite perspective, not from the delivery system perspective, but from that of the health plan, in particular, for-profit health plans are fairly aggressively now acquiring delivery system capability. But the delivery system capability that they are not getting into is on the hospital side. So when you look at a health system, particularly hospital-centric health systems, right? And now you have plans that are actually acquiring the delivery system capability to provide a great portion of care, right? Within that system, within that technology platform, within that EMR, but at the time when you need that information and data the most, which I would argue is at the hospitalization, in the ICU, it's in a different system, right? So if this macro trend continues to play itself out, which was something that was talked about many years ago, I think is very active without talking about all the deals that have been happening in the past 18 to 24 months, that fragmentation of care, particularly from the intensity of the inpatient side and then all else, particularly as this dynamic plays out of payers acquiring delivery system capabilities, I'm not sure the economics are going to be sufficient to be able to resolve that.
Great. Natalie, in the children's world, blessedly, most children are healthy, but those children that are sick frequently have chronic and multiple conditions that require an enormous amount of longitudinal care inside and outside the delivery system. How complete today is the aggregation from all the different social service organizations, home care organizations that interact with the sickest children who receive their care through our children's hospital, and you and your colleagues, the providers? Are you getting the type of information you need, and how can a future evolution of the electronic health record or related systems help you to provide that type of integrated and coordinated care that you need to optimize the lives of these children and their families?
Right. Yeah, it's a great question, and there's obviously lots of opportunity for continued optimization. And I think, as we've touched upon already in this panel, so much, especially in pediatric care, so much of health is not determined by the small amount of time that we spend with them, but by the larger socioeconomic factors that they're living in. And so I think there are examples where we have been very effective in getting the right resources together to truly improve children's lives. So, for example, some of the large pediatric collaboratives like Improve Care Now, which is focused on inflammatory bowel disease. KT Park at our organization is helping to lead that work here, but it is a national effort, and they have both collaborated with hospitals across the nation and developed really interdisciplinary care teams, everything from the dietitian to the social worker to the case manager, and really looking at how do you holistically change these children's lives. And again, they've used the EHR in this case as a tool to create structured documentation that both helps collect data that will, again, feedback, create this learning health system, but then also guides practice within the documentation itself. So I think there are wins like that. Another example is in our work around diabetes, type 1 diabetes. Again, very multidisciplinary disease process. You need your physicians, but you also need your dietitians and your educators. It's really about changing their entire lifestyle and supporting them where they're spending most of their life, which is hopefully at home or at school. And I think the EHR plays a role, and Priya Prahalad, who's one of our endocrinologists here, has helped create a registry for type 1 diabetics and is able to really identify some patterns for outcomes in our own population. So, for example, we see a lot of our patients who are in the Silicon Valley with utilizing higher levels of technology and having some better outcomes, and then we see some of our patients that are in some of our farther outreach areas with more challenges. And so I think what's exciting here is the role of digital health to really enable that kind of, again, multidisciplinary complex look at how do we actually impact healthcare? So for for example, taking the data that she got from the EHR, realizing that some of our patients in our outreach areas are not getting the same level of support or care that they need. She's helped create some innovative care models where they are doing video visits in the schools with the school nurse, with the mom, with the interpreter, with the dietitian in the room, and that's really enabling everybody to work together at once to provide that type of integrated care. So we have a long way to go in creating more, integrated and seamless systems, but I think some of the tools that we are starting to use, especially when we're using them with really creative physicians who understand the needs, we're starting to create better, fully rounded healthcare.
Thank you.
Natalie, as you were describing your work with individuals with diabetes, it reminds me, I think one of the fundamentals of our work in population health, and we had talked about this a little bit before, I think one of the fundamentals is we want to move averages, right? We want to have the average hemoglobin A1C improve. We want the average systolic blood pressure to improve. We want the average cost to improve. Unfortunately, a lot of our conversation in population health tends to focus on tails and just working on the worst. The individuals who have the worst level of control, or the small group of patients, 10 to 15 to 20% that account for a disproportionate share of costs. But if you accept the premise that our goal in population health is to move averages, you cannot focus on tails and move averages. That's just the math. Right? That's just how math works when you're looking at moving averages in a normal distribution. Now focusing on tails is important from a financial perspective because they can bankrupt you. But really, if you're going to move averages, you can't just focus on tails. So I question a little bit sometimes our focus on just the tails and individuals or populations that account for disproportionate cost or disproportionate utilization. You actually need to do something for everyone. And that is, I think, an important thing to realize as we work this sort of model of the technology, the data, the analytics, and the EMR, and the types of interventions. And I think what you were describing was very holistic and targeting a very broad swath.
Great. Mark, a lot of the patients that receive care in your delivery system live in very, very rural areas. And you've been an innovator in looking at novel ways to provide that care, including advances in telehealth. Can you give us some of the highlights of those programs, what's working and where are the challenges?
So we may be the only system that's represented in the room that has a hospital with a hitching post out front. So. And we actually do. So our day-to-day footprint's about the size of Italy, or about the size of the UK, but we have only 3 million people who live in that area. And some of the hospitals and clinics are literally 100 miles from the next town. And so out of necessity, we started to actually provide a lot of distance health to folks. That has actually now turned into a strategy. We currently have more than 100 teleproducts that are in day-to-day use at Intermountain, and now in 5 Western states. So we're actually expanding fairly aggressively to help other people. It's not a great revenue model at this point in time. We are not trying to extract patients from other hospitals and just fly them to our places. In fact, what we try and do is keep people in the least restrictive environment, as close to home and as close to their families as possible. And it ends up being economically okay, but we really think that in the future, this is going to bear a lot of fruit, both for the communities as well as for the hospitals that we're serving. Because as many as a third of rural hospitals could just go away in the next 10 years. They're not economically viable. And what we're finding is when we support folks, they do become economically viable. So just a couple of really quick examples of the kind of care that we provide and make these hospitals stay viable. First, antibiotic stewardship, huge problem across American healthcare. We have one team that covers the entire system. Everyone gets the same antibiotic stewardship, regardless of whether you're in a 20-bed rural access hospital or whether you're at one of our major centers. Secondly, telestroke. There's one Joint Commission certified stroke center in our state. It's at our place. It's at our flagship hospital. That said, we run a telestroke service that covers the entire system. You get the exact same care with the exception of intra-arterial therapy, which they can't provide at all the little hospitals, everywhere in the system. Amazing results. And then all kinds of things like tele-newborn resuscitation. So imagine you're in a little hospital that has passes at each end of the valley that get closed in the wintertime, and a mom comes in who's in preterm labor. And the team has not resuscitated a newborn who's going to be this sick for months and months. Well, it's really easy. We put one of our neonatologists on. While the mom's laboring, they do real-time training with the resuscitation team. Baby's born, resuscitation occurs, the neonatologist stays on the line. If the baby needs to be flown out, the family's actually already met the neonatologist, and their transition is seamless. This happens every day. It's part of our operating model. And now with the launching of our virtual hospital, it'll become a part of our commercial model as well.
That's great. Cool. I'm going to ask, just to give people a heads up, one final go-around question in just a moment, and that will be if you could think about the one thing you'd like to see more focus on, say in the next 3 years, that would help drive this transition to better management of population health, what would it be? So I'll plant that question for people to think about. But before getting to that, Brian, you've been with Health Connect now for about 16 years. You've really been instrumental in evolving the electronic health record system for Kaiser Permanente nationally. Can you describe the process of changing the system, or how it evolves, both with input from the people who are receiving care through KP and also through the providers that are using the system every day? Mm-hmm. What does that process look like?
That is a process of getting the information to the folks who understand. So it begins with, this kind of gets back to some of that conversation this morning of people who are alienated from the tools that they use or don't want to understand the tools they use. It's the pilot absolutely understands what goes on with the technology on their plane, but the physician is like, why would I want to learn about that? I'm here to see the patient. But not every physician is like that. Not every nurse or social worker or pharmacist is like that. So finding those folks who are interested in the technology, who sit side by side with others who maybe aren't as interested, and using them as kind of eyes and ears to help understand what's taking place, what people are struggling with. Also having panels of patients who are able to discuss what it's like using the portal or other pieces of technology and being able to get that feedback. And then funneling that feedback in ways that, kind of preserves and curates the meaning of it so that folks who think long-term and short-term about the tools in the system are able to kind of figure out, do we already have a solution for this? And this is a case of the future's here, it's just unevenly distributed. We need to get it over to folks who don't understand this, or is this a true gap? Is this a mistake? How quickly do we need to fix that? And is it internal or is it external? And because external is complicated, of course, Epic is our vendor, but there are many, many other systems involved. As you were saying from IBM earlier, there are many other systems involved. It takes kind of a lot of figuring out sometimes to say, okay, here's where the problem is, or here's where the investment needs to be to get there. So what we did was we built infrastructure that allows us to capture, understand, curate, and communicate that information, leading up to oversight and governance processes where we can kind of make those decisions.
Great, thank you. So Kevin, if we could start an easy final question with you. What one thing in the next 3 years to improve population health management value in healthcare?
I'm going to come back to the concept that I kind of started with, and to Taylor Davis, if he's still here. I thought it was really, there you are. I thought it was really interesting what you told us about organizations that really go through the process of good change management that drive outcomes, right? And I think that's the point I'm trying to make too. What I'd love to see is a model wherein care teams have the latitude to make decisions and have the resources to do their work. And they do that in a very aligned way. Technology serves to potentiate that. But technology won't solve that. That's why people on the same technology but who manage it differently are more successful. And the other side of that equation is the patient-centered piece. Now, we've said it way too much. We're all a little, sick of it. But I believe that the moment we truly drive towards patient-centered care and we put power into the hands of the patient as a part of that care team is the moment that Copernicus had when they decided to put the sun at the center of the solar system. And everything starts to get a little bit easier instead of creating really complicated algorithms to make something that doesn't work. So that would be my hope, that we could see practice redesign, that we could see those teams be given latitude and resources, and that we could see technology support that effort.
Thank you. Mark?
For me, it's personalized health leading to population health. So I'd like to see increasingly tools built into the system that allow people to get very much tailored information. So our depression algorithm now includes genomic testing for every patient, so that people get on the right drug as quickly as possible. It ends up paying economically also if you have a population health model. It's good stuff. The second piece is, let's just ask patients what they want in like real language and not talk about their heart failure classification score. Let's ask them, do you want to dance at your daughter's wedding? Right? And then we'll get real information about how we keep them well.
Great. Brian?
I really liked these examples that took the concept of population health all the way down to a telestroke event taking place, or that kid getting help in a remote area for managing the difficult disease the kid has. Ultimately, it gets down to the level of the patient. And, we have just at any given time a finite amount of resources, and figuring out how we can correctly allocate the resources to solve problems where it would make a material difference is the challenge. And, in our organization, I think we're pretty good at it for, the plain vanilla and maybe a little bit of other flavors too. But as technology evolves, more and more of these opportunities open up. And a lot of the fun and the challenge is figuring out how to match the organizational knowledge and capabilities with what these opportunities are. So looking ahead, the work is actually mostly people work and organizational work, and trying to understand how we can accomplish that as the technology keeps evolving.
Thank you. Natalie?
I completely agree. I think there's so much people and process work here to be done to really make sure that we are using the technology in a meaningful way, incorporating it into our workflows, and focusing on the outcomes for the individual patients. And I think outside of Kaiser, unfortunately, some of what needs to continue to be done is getting clinicians involved in advocating for the context that will allow us to do the right thing for the right patients.
Thank you. Rishi?
I do think that over the next several years, I sort of put forth this framework around measurement, resource allocation, and managing the risk. And I think from a very tactical perspective, that is what's going to be needed to move forward. I do think, though, in the next 3 years, we're going to have, as an industry and quite frankly as a country, a fairly difficult conversation around this topic of social determinants of health and its intersection with population health. And if please forgive me for a moment, but I think part of that is that we're going to have to stop using this term, social determinants of health. I think it's a euphemism that allows us to not say and talk about some very, very difficult things like poverty, income inequality, food access, housing access, racism. And I think until we are willing to actually, and I could see folks just now bristling a little bit about the way I kind of called it and said it, but you can't have the conversation about population health and managing risk without us also having that level of blunt conversation over the next couple years about what we're going to have to do as an industry and quite frankly, I think as a nation too.
Great. Thank you very much. Thank you to all the panelists.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.